Hi, thank you. No disclosures. So this is a case of an 83-year-old gentleman who had a past history of a subdural hematoma who initially presented to a local community urgent care with left leg swelling and coolness. They obtained a duplex, an ultrasound at that point, which was read out as a Baker's cyst with no DVT. So he was discharged with rest, ice, elevation for what was presumed a musculoskeletal injury. But 2 weeks later, he came into our emergency department with increased left leg swelling and what was described as bluish toes. And on physical exam, he had 2+ edema to the level of the knee, which he described had worsened in the last couple of weeks. There was a palpable pulsatile mass in his left popliteal fossa, and though it was a little limited because of the edema on exam, he did have a DP pulse on that foot. He had palpable pulses on the contralateral side, and he had some evidence of some earlier atheroembolic trash to his toes. So a CT was obtained at that point. Which, as you can see here, shows a large popliteal aneurysm, which measured 6.3 centimeters in its largest diameter. The runoff was a little bit affected by this, but he did look to have about 2-vessel runoff on this. So this, for the trainees in the audience, the other key piece of information is that he did not have any contralateral popliteal or aortic aneurysm, as we know the concurrence of aneurysmal disease in patients with popliteal aneurysm. So this is just looking at his CT in a couple of different views, because obviously the anatomy of the aneurysm is going to be important in determining the options to repair this. So when we consider how to fix these, the anatomy is going to be critical in determining whether open or endovascular repair is ideal. And in the case of open repair, the proximal extent is really the biggest determinant on whether or not to do a posterior approach. You can't really get north of the adductor hiatus. The presence of conduit is also going to affect that. It can be challenging, though not impossible, to get to the great saphenous if from a posterior approach. But the benefit of the posterior approach is that you can open the sac, decompress it, and ligate the feeding geniculates from that. So if you do have somebody who has compressive symptoms, sometimes that is an attractive option. The other thing to consider when you're looking at these people is the runoff. In people who have poor runoff, we know that they don't do as well with endovascular repair. And thirdly, just like within other areas where you're dealing with aneurysmal disease endovascular, you want to take a look and see what your landing zones are going to be. So these are just some quick. Obviously, man decided to do endovascular repair with this patient. He was adamant not to have an open surgery. So these are just some images from our initial part of our angiogram. This doesn't really fully demonstrate it, he looked like he had a good 2-vessel runoff there. So this is I don't really know why it looks like a Muppet. I think we were still trying to figure out how to use the marking software in the OR. But this is the best shot that we had that showed the extent of the aneurysm with the bony landmarks. And I put this up here because one of the key things that I think you need to do when you're doing these endovascular is flex these people in the OR so that you can see the with a wire through there, so you can see how the distal SFA and the POP, the flexion points of that. But generally, if you look where the top of the patella is, that's usually an area of high mobility of the vessel. And the reason that that's important is because the distal SFA and the POP has a lot of mobility in the flexion that is really underappreciated when you're looking at these people with just a straight-on angio. So it's critical that you move these people around when you're doing your angio. This is from the JVS in 2018, which shows some of the changes in the dynamics of this vessel when you're walking, sitting, and kneeling. And I've definitely seen a lot of failures of endovascular management of both occlusive and popliteal disease when you don't really take this movement into account. So, and a recent study that came out earlier this year looking at the patients who were treated with Viabon. These were all for aneurysmal disease in the POP. Showed that there is a higher stent-related complication in patients who have the stent crossing the hinge point. Endoleak being the most common, but also thrombosis and migration, though the difference in overall patency remained the same. So obviously this can't always be avoided. When you have these big aneurysms or these long aneurysms like we had, you don't really have a choice in terms of crossing that hinge point. But it's not only important when planning your landing zones, but also if you're going to be needing to do overlap of multiple stents, you really try to do everything you can to avoid having one of those stents land anywhere close to your hinge point. So IVUS is key in these cases too, particularly in an aneurysm like this where you have a lot of thrombus that you're just not going to fully appreciate the preciseness of where the aneurysm starts and ends on basic angiogram because of that. I should say very quickly, this is a off-label use of the Viabon in the U.S. It is not actually indicated for this, though there isn't really any other options, and this is a pretty widely accepted use. The Viabon is a pretty widely accepted stent for patients with aneurysmal disease. So oversizing, generally about 10 to 15%, but I would caution you, having dealt with these, oversizing in these particular cases, it does give you an increased risk of thrombosis. So. The one other thing that was particular about this case is he had a pretty large geniculate that came off of the distal extent of the aneurysm, right about where we were getting into our landing zone. Having dealt with doing late decompressions of these for expanding sac size from endoleaks, I have a pretty low threshold to try to embolize the geniculates if it's going to be relatively straightforward. So for this one, we used a buddy wire technique of a 0-8 wire, used one ruby coil to take care of that. So. Our completion angiogram here showed a good result without any backfilling. So we ended up using Viabon 6.75 distally and then built up with the Viabon 8, and then we used the one ruby coil for the geniculate. I always balloon the entire segment, not necessarily oversizing, but just to try to get take care of any infolding, because that's also can compromise your long-term results. Ultimately ended up with 2-vessel runoff, and I maintained this guy on dual antiplatelet for 3 months and cautioned him to avoid any aggressive knee flexion, so gardening, kneeling, anything like that. So we had a 10-month post-op CT, which showed a good result. I was paid particular attention to try not to have any of those overlap between stents in any of my flexion or tortuosity points. And we had showed decrease in sac size. So. The SVS published some clinical practice guidelines earlier this year for the management of POP aneurysms. Just as general review, the indications for repair is any aneurysm greater than 2 centimeters, unless they're a high-risk patient. You know, there's good evidence that you can follow them out a little bit larger. But anybody who has thrombus, poor runoff, or evidence of embolization is recommended to be repaired. For asymptomatic patients that are have good life expectancy and a good vein, this recommendations is still generally towards open repair, but endo is definitely becoming more of a widely accepted option. Thrombolysis is indicated for people who have thrombosis or significant tibiopedal disease, and they do recommend sac decompression for patients who become symptomatic or have a sac expansion later on. So again, just some pearls when you're approaching these patients. Pay attention to the runoff, and remember if there is really any question, and it could go either way, sometimes lean towards open repair in those patients. Definitely use IVUS when sizing and determining the landing zones in these. You want at least 1.5 centimeters of landing zone and some good overlap, and particularly more in the larger aneurysms where you can get some stent migration. Oversized, but not too much. Definitely use judicious leg flexion views so that you can see exactly where you're going to get the movement of your vessels and avoid landing any stents at that point. Just like in your thoracic aorta, you want to build smaller to larger, usually distal to proximally, And don't be afraid to embolize the geniculates. And I talk to all these people, avoid any sort of kneeling activities in the long term, and surveillance usually 3, 6, 12 months, and if all looks good, yearly after that. So, thank you.